Good morning, everyone. I know folks are still sort of slowly logging on. I hope the snow is not impacting anyone, but I'll go ahead and introduce myself and get started. So good morning. Welcome back to week 2 of our Cardio-ECHO Clinic Weight Management and Behavior Change Cases and Discussions. I'm Jessie Lewis, the clinic coordinator, and I think I'll go ahead and hand it off to Dr. Rao and we'll get started.
Okay, thank you, Jesse, and thanks to everyone for joining us this morning. I hope the weather isn't affecting you too much. Looks not too bad here in Northeast Ohio right now. So this is our second session, and I just wanted to go over the format. So I'm going to give a brief talk, try to keep it as short as possible. And then we will have our case presenters. In this case, it's going to be Austin and Sarah Renner, who are going to present their cases, and we'll ask for any questions about the cases. And then if there is a specific psychological or psychiatric issue, which often intersects, of course, with weight management, I will ask Danette to comment at that point. And then we will go on to our lead discussants this week. We have Liz and Jim who will comment about those things. So I just want to give you an idea of the landscape of what we're going to accomplish this morning. So this is our structure. I'm going to try to stick to 10 minutes. This is a really important topic, so we'll do the best we can. Next slide, Rick. Disclosure statements. I had mentioned earlier that I do serve on the board of Dan & Whitewave, which is a division of Danone, which of course you know is the yogurt company based in Paris, France. I won't be discussing any products or relationships with them today. Next slide. This is a reminder about person-centered language recommendations, which Liz went through last week as well. If you have any questions, you can address those to Liz or to myself at any point. So let's talk about communication. So consistently, this goes back in my experience in the field, which goes back about 20 years and begins with children and adolescents. Consistently, everyone says, you know, it's not about knowing what medicines are out there or measuring BMI or managing lipids or any of those things. It's communicating about weight. And within the body of communication, it's that initial discussion, which is so crucial, which we'll talk about in a moment. Next slide. So I want you to describe the opening the door approach to beginning weight management discussions. Preferred terms, which Liz had actually gone over a little bit last week, but we will go over them in the context of discussing weight, specifically not patients, not in the context of other problems. List a minimum of 3 additional key communication tasks essential to effective weight management counseling. Next slide, please, Rick. So I did lead this effort within the American Heart Association. This paper is looking rather old now, 2011. It's hard to believe that that's been 11 years already. But I was the chair of the obesity committee back in the late 2000s, early 2010s. And, you know, I was asked, well, what are your priorities? And, you know, the obesity committee is a multidisciplinary group. Includes all sorts of people, not just physicians, but PhDs, basic scientists. And prior to this, people are concerned about vascular biology and all sorts of things. And I said, communication is probably where I want to focus my energies for the next 3 to 6 years or so. So we brought together a group of leading experts and other organizations. You'll see that the Council on Cardiovascular Nursing, our nutrition council within the AHA, Council on Clinical Cardiology, especially society, and also the Society for Behavioral Medicine, endorsed these recommendations. This is how we ought to communicate about weight management in busy ambulatory settings. Now, it doesn't encompass everything, but it does encompass a great deal of what we're going to discuss this morning. Next slide. So first of all, in terms of terminology, the word obese is probably not the best one to use. We've already talked about person-centered language, having obesity. Fatness is a no-no. Do not mention those terms in any clinical context or even discussing them. Adiposity is really, you know, I remember our nutritionists in the past would say, you know, has a large amount of adipose tissue. I think it's confusing. It's not meaningful. I wouldn't use it. Next slide. Heavy is definitely out, of course. Next slide, please. And weight is the preferred term. The core principles we established. Now that paper I showed you is 30 or 40 pages long, and we don't have time to go through all of it. But of course, to show empathy. And to discuss the shared experience and say, well, I know it must be hard for you to have to go through this and to have been struggling with your weight for a long time. If that's not an experience you can share, you can certainly point to other patients. And I do that quite often every week. I say, you know, there's somebody just like you who's in the same boat, and it's after the holidays and they've gained some weight and they've gotten back on track. You need to be collaborative in your approach to it. One of the things we found in the early days was that, well, I will manage your hypertension, your diabetes, and your lipids and other things, but I just need you to go out and lose weight. You need to lose 30 pounds. Well, that's not at all collaborative, is it? I mean, that's just, well, how do I do that? What do I do? But that's unfortunate. That's been the approach for a long time. Another key principle that emerged from literature with patients and from the experts is time. Often, and this still happens, of course, weight management is thrown in at the end of an encounter. Okay, looks like your diabetes is doing fine. You know, if you lost 10 pounds, it'd do even better, but I'll see you back in 3 months. And of course, the patient is not necessarily confused, but then they're charged with something on their own, but they feel like you didn't really address the issue in a sufficient way. Always recognize successes. Medicalization I will talk about in a moment, and reflections on recommendations. Allow the patient to reflect upon things that you recommend, which I know Jim will talk about in the context of motivational interviewing, but this is a core principle even at the outset. Okay, so here's a case scenario. This comes from the repeating at the same time, which has made this much less confusing for me. Even getting used to Central Time in Chicago has been a bit of a source of confusion, but this is a case from there. So Robert's a 48-year-old man with obesity, by the way, brings in his 15-year-old daughter, Lauren. Lauren is 5'6", 190 pounds, BMI is 30.7, so she has obesity. She's generally healthy, no problems at school. Physical examination is unremarkable, which you would expect for a 15-year-old. She has had obesity for about 7 years. Both mom and dad have obesity, so does the younger brother. So my question to you is, nobody has talked to this family about the issue of weight. What is your starting point? How are you going to bring this up? And I deliberately chose a case of an adolescent girl because this is the most sensitive population in my experience. And if you are not careful, she will shut down. You will not get another chance. In fact, it may compromise your care for other things, asthma or immunizations or anything else, because she will associate a visit to you with feeling ashamed. So watch your step. Let me know what you guys think about how you might start.
I would say that rather than focus so much on the weight and being overweight, try to focus more on wellness and how they could be healthy. I know this firsthand with teenagers, and I couldn't imagine trying to navigate that. But it seems like that takes some of the stigma off of it.
Yeah, so Kathleen's raised an important point. Stigma is one thing you want to avoid. So let's look at some examples, and I do like what you said. Next slide, Rick. So here's some options with this. Okay, that's addressing it to dad with the 15-year-old, not a 5-year-old, 15-year-old in the room. Not a good idea. It should come as no surprise to you, Lauren, that your weight puts you in the obese category. Let's discuss this. This is really, really, really shameful. You do hear these things, though. I hear them from residents and fellows all the time. That is going to make her shut down. It's embarrassing. How interested are you in losing weight? You haven't even addressed the issue yet. Then you're asking about how interested are you in a solution that you have decided is appropriate for her. That's not going to work. This is terrible. Robert, he's talking to dad, who, remember, dad has obesity as well. So does mom, so does younger brother. Lauren is very heavy for her age. This is something she needs to work on. Don't say that. So here's a more prescriptive approach. This is not something I will tell you that I had made up. Well, I was involved in developing these approaches, but this has been adopted by the National Academy of Medicine in their book on the roundtable on obesity solutions. So the prescriptive approach is something we recommend because this is a real minefield. And all of us have probably been in a position where we haven't tackled this issue very sensitively. And that's why I tell people, especially newer clinicians, just follow it step by step and you can't go wrong. So first thing you do, step one, express concern. I am concerned about your weight, and be sincere about it. Of course, you're concerned about it, right? It puts you. The next thing is don't even let them take a breath. Right? You explain why you're concerned, and you will notice the reasons here. it puts you at risk for diabetes, heart disease, hypertension, et cetera. Just list whatever it is. It doesn't matter what it is. It can be obstructive sleep apnea, whatever you believe the patient would understand, right? If it's a teenager, you might say, this is going to put you at risk for problems later on, and you can list a few of those. But you'll notice that the key principle in the step is it medicalizes the issue, okay? We're not talking about other aspects of weight. And that's our job as healthcare professionals. The number three is this something that concerns you as well. So you are soliciting interest, or in another way, asking permission. And the fourth part is this something we can work on together? Notice the tone here. Is this something you're interested in as well? Well, if you are, there's a there's a Weight Watchers group that meets here at the clinic. You might want to join. That's not a good way to do it. You are offering your help, and you're not saying, I'm going to help you. You're saying, is this something we can work on together? I have recommended this approach since 2004 to both adult and pediatric providers. And I've challenged anyone to tell me that somebody has said no to this. I've yet to hear this from anybody so far in 18 years, okay? Now, people will say yes. It doesn't mean that they're going to jump on board and be enthusiastic, but this is called opening the door. You have gotten past the most critical stage in communication. Now you can talk about habits. Now you can talk about exercise. You can talk about other things because the patient has agreed because of your sensitivity to discuss those issues. If you do not open the door correctly, you won't get any further than that. So no one has ever told me that the patient has said, no, absolutely not. Don't want to work on it with you. Don't want to talk about it. I haven't heard that yet. I'm still waiting. So next slide. Here are some of the don'ts. There's a long list of them. Never, ever emphasize the cosmetic benefits of weight loss. Here's my own personal feeling. It's none of my business. Okay. It's absolutely, as a physician, or as any healthcare professional, that's not what I'm in the business for. In fact, in our Fit or Me clinic, I have a lack of enthusiasm for people who are there who say, I want to lose 10 pounds and my daughter's wedding is coming up and I want to look better. That's not what we're here for, okay? What if you, as a healthcare professional, have obesity? This is something that is brought up very, very frequently. And the original, first of all, there's a lot of evidence that shows that physicians and other healthcare professionals who have obesity are less likely to discuss weight with their patients. Of course, they fear the criticism. Oh, well, you're no picture of health yourself. The idea of feeling hypocritical. The thinking on that has changed a lot over the last 5 or 10 years. And in fact, you can use it to your advantage. If you do have the problem, you can say, I'm concerned about your weight. And you can step in and say, this is something I struggle with as well. Okay. And I'll tell you why it's important to me. And here are some of the ways that I'm trying to tackle with it. I may not always get there, but I can at least share your experience. The response from patients invariably has been extremely positive. We say, oh, well, Dr. Smith, he also has the problem, and he's kind of guiding me through this. And I feel like we're more in this together. If you are noticeably thin, you have to be careful. Again, this group of people is less likely to discuss weight with their patients. What you want to avoid are points such as, well, it's pretty easy. You just go to the grocery store and you avoid buying all the junk. That's certainly what I do. That's not a collaborative approach at all. So just be careful about what you say, but people still appreciate someone who is taking the issue seriously and has been successful in achieving or maintaining a healthy weight. That can be a positive as well. This is the number one issue we find. I haven't found it so much among adult providers, but certainly in kids, this is a huge problem. And that is, it's so easy to downplay the issue, right? And it's rare that a patient himself or herself raises the issue on their own. But when they do, you must address it seriously. So for example, if a patient comes in, let's say she's 60, 65 years old, she's just gotten weight, her blood pressure is not bad, and her BMI is over 30, and she says, doctor, how's my weight anyway? It looks like I've gained a little bit of weight. If you say something like, yeah, it's true, your BMI is over 30, but you're active, you're taking care of yourself and you have a large frame. The problem with that is that is what gets seeded with the patient. And the weight never gets, it's very hard for anyone subsequently to address the issue seriously. We found this with pediatrics, especially when a patient goes to one childcare provider who then says, well, yeah, your son, yeah, of course, yeah, his BMI is over 95, but you guys are bigger people and he's active and he's trying to make changes. So don't worry about it. Boy, does that make our job a lot tougher in the future. And it sends the message that this is not a serious problem. This is not a serious health issue. We wouldn't do this with any other medical illness. We shouldn't be doing it with obesity either. Okay, I'm going to stop there. I think I went a little bit over time, but let me ask you for some questions just for a couple of minutes and then we'll move on.
I guess one kind of question, if the patient's goal for their weight loss is cosmetic and that's really their only goal, in a motivational interviewing context, like, should you lean into it in that case?
Yeah, I think that's a great question. We ask all our patients, why do you want to lose weight? And there's always a cosmetic element to it. Most of our patients are women. They say, well, I want to be able to fit in my clothes. I don't like the way I look. And I don't think that's an illegitimate reason for them to raise it. Okay. But what I think that, Austin, I think is you should not raise it first off as a benefit. Let them raise the issue. And as far as leaning into it, I tend to avoid it personally. It's like, well, you're right. You're probably a size 8 now. That's fantastic. Even if that's something that they brought up, I don't feel comfortable doing that. Liz, sorry, not Liz. Jim, do you have any comments about that in terms of how you?
Yeah, that does happen sometimes. And when that does happen, what I do is ask, okay, so I'll reflect that back. I'll say, what other benefits might you get from losing weight, from being at a weight that you're happier with? And they'll invariably say, well, I might be healthier. I might avoid some of the health problems that my family members have had, et cetera. So usually if you probe, or really invariably, I think I've found, if you probe just a little bit, then that door will open. And then you can reflect those things back too. And then what I usually do is then summarize. So, wow, you've got some really powerful reasons here. You'd like to look better, but you're also going to be able to reduce your risk of heart disease, diabetes, and you're having some problems with your knees. And that can definitely improve osteoarthritis risk as well. So these are really uniquely your reasons. And so, what I ask people to do is write those down, and that's your motivation. That's why you're here to see us. And think about those things. Add to that list as time goes on. So,
thank you, Jim. That's great. In fact, I know I haven't talked to Liz about this. I think this should be a language issue. I know that at the National Academy of Medicine, Bill Dietz, who was former director of the CDC, who's on the committee as well, and I were discussing this. We don't think it's appropriate. I agree with him to tell a patient after they've lost weight, you look great. We have a patient in our program who's lost 150 pounds and he comes in and I don't say, hey, you're doing great. I say, you're doing great. I don't say, you look incredible. You look fantastic. You look like a changed person. I never say those things because it is getting at that appearance issue. And I'm not saying those things aren't important, but if you really want to lose 10 pounds to look better, there are other places to go. As far as I'm concerned, but people might disagree with that. But great point, Austin. Okay, I think we really do have to move on.
Thanks, everyone. Just a reminder that we do record the clinics. You can find the videos of our didactic presentations on our website. For this current clinic, we do ask that you make an account on Cardi-OH.org. But please also know that any of our previous TeleECHO clinics are also available to you as a resource. And then just our usual wrap-up reminders. So you should have the post-clinic survey in your inbox now. Please complete this by tomorrow at 5. That feedback is extremely helpful. So thanks for completing that from last week. And then just a reminder, I've emailed this to the group, but I will be out of the office for the next couple of weeks. So Lauren Wooster will be taking over my ECHO duties. And so her email is listed here. Feel free to reach out to her And of course, I'm still available to you through tomorrow as well. So I think that is all I've got, and I hope everyone has a great rest of your day, and we'll see you next week.
Thank you, Jesse, and enjoy your time away. And everyone have a wonderful day. Stay warm and safe. We'll see you next week. Bye-bye.